I'm going to talk a little bit about cardiovascular diseases and drugs that are used to treat them. So first off, what happens when somebody needs, what happens when somebody has cardiovascular disease? So inside of our bodies is our heart, okay? And there are blood vessels going into the heart. And these blood vessels supply the heart with oxygenated blood. And sometimes these blood vessels get something called an atherosclerotic plaque. Essentially what happened with an atherosclerotic plaque is that from inflammation or from, can't think of the word right now, cholesterol or something building up on the sides of the wall, macrophages came in and they ate up this, this fat or whatever. And when they ate it up, the macrophages turned into these foam cells, and then you had the tissue kind of form over and make this little plaque around it. Okay, so it's full of all these macrophage foam cells that are just like these dead foam cells, and this makes it difficult for blood, oxygenated blood, to supply the heart with its demands. And so when you start to exercise and the heart starts to pump a little faster, the heart says, I'm not getting enough oxygen. And when the heart's not getting enough oxygen, it kind of freaks out a little bit. And it sends out something called Atrial Natriuretic Peptide, okay? And this atrial natriuretic peptide, and it's called natriuretic peptide, whatever, these are the atria, so it comes from the atria, and it goes down into the renal system, down here in your kidneys, okay? And it tells in the juxtaglomerular apparatus, which is the little place where I'm not going to go into it, hopefully you already know about it. Anyway, it has a signal there to basically do something that results in in your body retaining water. It holds on to salt. Water follows salt. And so your body retains the water. Now, why did your body do this in the first place? Why did it release this natriuretic peptide? Well, sometimes the reason why, or perhaps maybe what your heart was, I don't say thinking, but sometimes when the heart isn't getting enough oxygenated blood, it's because the person doesn't have enough blood. In other words, because they're dehydrated, okay? So in this case, it's not getting enough blood because there's atherosclerotic plaque, okay? I don't think people got these, 10,000 years ago. People probably didn't even get these, 200 years ago. So now the heart's not getting enough blood, but it has nothing to do with the fact you don't have enough blood. It has everything to do with because your coronary arteries or whatever are all clogged with atherosclerotic plaques. And so your heart says, I'm not getting enough blood. I need more blood. And so it sends out atrial natriuretic peptide, goes down to these kidneys and says, hold on to water because I need more water. I need more blood. And so these guys hold on to water by retaining salt. So you pee less, okay? Well, what's that going to do? Well, now you're going to have more blood. Now, you already had enough blood. You didn't need more blood. What you needed was this to go away. But your body doesn't really have a way to do that because it doesn't know how to handle these weird things we're putting in our bodies these days, okay? So now you've got more blood. Well, when you fill up a balloon with air and you make it bigger and bigger and bigger and bigger, after a while it kind of gets to this tight kind of place where there's lots of pressure, okay? So that's kind of what's happening with your body. It's like a balloon filling up. People get edema where the fluids go into their legs and their legs get all swollen, okay? With fluid, that's edema. And also, you look at their blood pressure. So you have systolic blood pressure and you have diastolic blood pressure. So the first one on the top here, normally it's like 120, okay? And that means that when your heart is pushing down, okay, that when your ventricles are pushing blood into your body, how high is that blood pressure? And how much pressure does it have? Well, when you have too much blood because of the atrial natriuretic peptide, you have too much blood, this can get up really high. And when it gets up really high, you have so much blood, so much pressure, your heart has to work a lot harder in order to push this blood around the body because there's so much pressure in there. So when you're in order to compensate, excuse me, I did that wrong. In order to compensate for all this pressure, your heart has to get stronger, has to make more muscle. And you think, well, that's good, it's making more muscle. That's not good. They call it hypertrophy, okay? So you get ventricular hypertrophy, where essentially your ventricle, your heart muscle gets so thick with this muscle that there's like no room in here anymore for blood to push out, because your body, your heart has to push so hard to push all this blood around your body, and so you get hypertrophy. Hypertrophy causes all kinds of terrible problems. For one, your cardiac output decreases. Why does it decrease? Well, because normally every push had this much room. That's plenty of blood. That's a big, splash of blood into the body. Well, now because this muscle's so huge, boom, you have like only this much. It's cut way down. So that decreases cardiac output. If you decrease cardiac output, what's going to happen to the rest of your body? Well, your heart can't push the blood around your body good enough. You're going to get tired really easily. Your heart, for one, so if before you had, this much tissue that needed to be oxygenated, well, now your body has this much tissue, and it's harder for your heart to get that much blood to supply it, especially if you have an atherosclerotic plaque that's preventing blood from getting to this muscle. So this now has a really high likelihood of becoming ischemic, okay? Ischemia is when tissue isn't getting enough oxygenated blood. And so this tissue, with even just a little bit of exertion, you go for a little run, and all of a sudden your heart's like, oh man, I've got all this muscle. I have massive needs for oxygenated blood. I'm not getting it. It's sort of like when you run, your legs are killing you. Your heart's doing that. And so it becomes ischemic. And if you don't slow down or find some way to get more blood to your heart, then this tissue is going to die, okay? So if you have a stable angina, okay, a stable angina is like heart pain that only happens when you exercise. What you can do is you can stop exercising, and the pain only lasts for 20 minutes or less. You can stop exercising, and then your heart's going to work slower, so it has less oxygen demands. So this, usually the 70% occlusion here, it's enough. It's okay. You rest, the pain goes away. You exercise, the pain comes back. You rest, it's okay again. So you can do that, or you can give the person something called nitroglycerin. Okay, nitroglycerin. What it does is, it's kind of a complicated process, but essentially nitroglycerin goes into your body and it triggers some signals that result in the calcium inside of your sarcoplasmic reticulum, prevents that from coming out, and also it kind of gets something active called myosin light chain kinase phosphatase, and this phosphatase takes away the phosphates from the muscles in your smooth muscle. And so in your blood vessels, normally they're tightened down like this. It basically takes away the phosphates and takes away the calcium, and that's what kind of needs to be activated in order for it to work. And so it relaxes that smooth muscle in your blood vessels. And so it takes a blood vessel with an atherosclerotic plaque like this. It doesn't change atherosclerotic plaque, but it increases the width of the blood vessel. So now you can get more blood through here. Okay, that's one way you can do it. So one was resting. Resting decreases the oxygen demand, so there's less here. The other one was to take this blood vessel and to make it bigger with nitroglycerin, okay? So what if you have now, you had a stable angina, now you have an unstable angina. Let me tell you what that is. This is where essentially this blood vessel, this atherosclerotic plaque, has ruptured. It's opened up, and you've exposed, collagen and fibrin and whatever, and it's triggered a clotting cascade. So now you've got a clot here, a thrombus, right there. And that thrombus is obstructing the pathway. Well, this is unstable because it wouldn't take much for this thing the thrombus to grow and obstruct the entire blood vessel leading into your heart, completely cutting off part of your heart with enough oxygenated blood to keep it alive. So that's really unstable. That's scary, okay? So the other thing with an unstable angina or unstable heart pain is that stopping exercising isn't enough. I mean, this still hurts even when you're not exercising. So even when you sit down, it still hurts, okay? So you need to give this person nitroglycerin because resting wasn't enough. With a stable angina, you can rest, you can give nitroglycerin, that's enough. With an unstable angina, nitroglycerin is what you need because resting was not enough, okay? So you give them nitroglycerin and it opens this up a little bit. But it doesn't take much for this thrombus to grow and obstruct the whole thing. And if it obstructs the whole thing, now we're looking at a myocardial infarction. Before it was ischemic, the cells weren't dead; they were just hurting. They were in a damaged state. But now they're gonna die. Okay, so here, this heart, bam, big ischemic area, big area that dies. And the scary thing about heart muscle is it doesn't grow back. Okay, so now you've got this big area. You have a myocardial infarction. Totally blocked off, greater than 20 minutes, more than 70%, or actually complete obstruction. And now, big pain radiates up into your jaw and your arm. This is bad, okay? And these cardiac myocytes are dead. And when they're dead, there's a couple things that can happen. First off, since these ones are dead, these guys are going to have to work extra hard in order to keep you alive. So they are going to get super hypertrophy. And that super hypertrophy is even worse, blocks us off even more. So this person's in bad shape. So you can kind of see how this progresses. Now, there's something we could have done at the very beginning that would have slowed this whole process down and perhaps prevented them or at least slowed down the process of getting this myocardial infarction in the first place. And that was long ago when their heart first sensed that it wasn't getting enough blood. And it set out this atrial natriuretic peptide, told them to hold on to water. Okay? Way back then, what they could have done is they could have taken something called an ACE inhibitor. Usually they end with pril. A pril suffix, so Captopril, Enalapril, those kinds of drugs. They could have taken an ACE inhibitor. Now let me explain what ACE inhibitor is. ACE isn't like, yeah, I'm an ACE, no, it's not like that. It stands for Angiotensin converting enzyme. Now, let me show you how this works. So there's a process. You have something in your body called angio makes you think of blood vessels. Tense makes you think of tensing blood vessels. Tensinogen. So it's like something that's going to generate, or like the first of these blood tensing molecules. Okay, I believe this is produced by your liver. Okay, angiotensinogen is converted into angiotensin 1 by something called renin. There's renin. I'm just going to put ANG1. So angiotensinogen is converted into angiotensin 1 by renin. Renin, if I remember correctly, is what's secreted from your kidneys. And the reason why you remember that is renal, kidneys, your renal, okay? Renin comes from your kidneys, from your juxtaglomerular apparatus. So here's a kidney. There it is. Secretes renin, okay? So renin, is I believe this is triggered in response to I don't remember. But basically it's triggered in response to conditions where your body thinks you need more water. So it says, okay, we need to hold on to more water. So what are we going to do? Or we have low blood pressure, put it that way. So yeah, with low blood pressure, and so it releases this renin. Angiotensin 1, then angiotensin 1 is not very active. So angiotensin turned into angiotensin 1 because of renin, kind of cleaved the molecule or whatever. But angiotensin 1 isn't very active. It has to turn into angiotensin 2. Excuse me. Ugh, I have to sneeze really bad. Excuse me. Angiotensin 1 has to turn into angiotensin 2 in order to be active. So this is where our ACE inhibitors come in. Okay? Angiotensin 1 or angiotensin 2 converting enzyme. And I believe that comes from your lungs. I can't remember off the top of my head. I'm just free thinking this through here, okay? So angiotensin converting enzyme changes angiotensin 1 into angiotensin 2. So if we could stop this angiotensin converting enzyme, we could prevent angiotensin 1 turning angiotensin 2. And if we could do that, well, what does angiotensin 2 do? Angiotensin 2 does a lot of stuff. It's an very active molecule. It goes to your blood vessels. This is a blood vessel. And it tells them to clench down and get really tight. Now, why is that beneficial? Well, if you don't have very much blood, your blood pressure is low. Let's say that I slit my arm and there's blood squirting everywhere. Well, if I don't have very much blood, I got to do two things. One, I got to get more blood, or I can make my entire container of blood, all my vasculature, smaller so that it doesn't actually need more blood in order to increase the pressure. Now, that seems kind of complicated. Let me put it this way. Here's a bottle of water. There's some water in the bottom of there. And let's say that up here is my brain. And my brain needs to get oxygen, but there's just not enough blood. That didn't work. That's okay. There's not enough blood to get the oxygen in this blood up to my brain. Well, I can do two things. I could fill this up to there, or I could do this. Squeeze down on the container and squeeze the blood all the way up. Oh, look, now it's up to the top. See, that is essentially what angiotensin 2 is doing. It's squeezing down this container, and it's getting the blood with the oxygen all the way up to the top without adding any more water in there. Okay, see how that worked? So if I were to, this is when it was full. Now angiotensin 2 is causing the blood vessels to squeeze down. Now it's getting the water all the way up to the top. So that's kind of how it works. So now I didn't need more water. I had angiotensin 2 vasculature squeezed down, and it was able to have enough pressure to get the blood everywhere that it needed to go. Also, it works, angiotensin 2 also triggers something called aldosterone. Aldosterone is something that, I'm going to go into all the details, but essentially tells your kidneys, says, kidneys, hold on to more salt, retain salt. And if your kidneys retain salt, water just follows salt around. Salt goes over there, water is going to go over there. If salt comes over here, water is going to go over there. So it holds on to the salt, and the water says, well, I'm going to follow the salt. It follows the salt, and follows the salt back into your body and out of your details. Essentially, you don't pee it out, okay? So you keep the water. So that's kind of how this works. Let's talk about some drugs. Okay, first drug here. Losartan, also Cozar. Okay, so this is an angiotensin receptor blocker. How does this work? Sometimes they call these ARBs. A-R-B. Angiotensin receptor blocker. Okay, well that's kind of interesting. Angiotensin receptor blocker. So that means, here's the angiotensin. Let me make sure I'm getting this in the right part of where this is blocking.
So it says the receptors are located in vascular smooth muscle and stimulation. Okay, so yeah. So essentially what's happening here is that an ARB goes to the vasculature. Now this angiotensin, let's say it's a little molecule that looks like that. Okay, this goes down and it finds the vasculature and it binds to the receptors on these blood vessels. And when this binds, this angiotensin 2, it would cause the blood vessel to get really tight and small. Okay, so what if we gave somebody a drug that went over here before this guy could get there, and he looked similar, but he blocked it. He blocked the receptor. He blocked the receptor so that when angiotensin 2 comes along and tries to connect and cause a reception or cause a signal to happen, cause this thing to clamp down, it can't get on there because angiotensin receptor blockers are in the way. Well, that would work. If that happened, the person's vasculature wouldn't clamp down, it would expand. And if it expanded, their blood pressure wouldn't go up to 200 or whatever. Their blood pressure would stay low. Okay? So if you go back to the thing I was talking about earlier, their blood pressure now doesn't go super high. If their blood pressure doesn't go super high, they don't get as bad of hypertrophy of their ventricles. If they don't get the bad hypertrophy, they're less likely to have a higher demand and the decreased cardiac output and all those other things in this bad cycle that leads to bad stuff happening. So Losartan, let me write this down. Losartan. Losartan is an angiotensin receptor blocker. It's an ARB, okay? So that's the drug we just talked about. Where does it work in this whole process? Right there. What's it going to do? It's going to decrease your blood pressure. If you decrease your blood pressure, that's good because now your body's not going to freak out and end up doing all those things we talked about earlier that are going to kill you. So make sure I got everything here. It looks like it says these receptors are located on the vascular smooth muscle and stimulation results in vasoconstriction via GQ protein coupled activation of phospholipase C, which causes an increase in IP3 and DAG, mobilization of sequestered calcium. Okay, so it looks like essentially, it's stopping the whole smooth muscle from occurring. All that's what all that stuff ends up meaning. Arteriolar and venous vasodilation. All right, very good. It says ARBs can block both ACE and non-ACE, angiotensin converting enzyme, mediated angiotensin 2 synthesis. ARBs do not impair bradykinin clearance. Okay, that's a whole other system. We'll talk about that in a little bit, hopefully later in this. So when do you use this? You use this in the case of hypertension. So if a person has hypertension, you can give them Losartan. So sometimes when you give people an ACE inhibitor, which was the first one, Acetaolami, that inhibits ACE, like Captopril or an Alapril, they can get, it's kind of complicated, but it ends up messing with their bradykinin, and they develop this cough and angioedema and some things like that. If that gets really bad, then you put them on Losartan, which doesn't have those same consequences. Okay, so side effects though, hypotension, that totally makes sense, especially in sodium depleted patient, and also it can cause acute renal failure and hyperkalemia. Okay, there it is, Losartan, discussed. Okay, now here's another one, Aliskiren or Aliskiren. What's this drug going to do? Let's talk about it for a little bit. Talked about Losartan and what it did. Now let's talk about Aliskiren. Now remember here we talked about how you have your liver, and your liver produces angiotensinogen, and then renin ends up binding to angiotensinogen and changes it into angiotensin 1. Well, what Aliskiren does is you can think of it killing renin. Ren doesn't actually kill renin. What it does is it turns off the effects of renin. Aliskiren goes up here, binds to angiotensinogen, and prevents renin
from being able to bind to it. So it essentially turns off this whole process right here. Aliskiren does not allow, this step is prevented. And so if you were to take this, what you'd see is you'd see decreased levels of angiotensin 1, which would of course cause decreased levels of angiotensin 2, and you'd see a large amount of angiotensinogen. Whereas if a person was taking an ACE inhibitor, like Captopril or Natriuretic, that prevents angiotensin 1 to converting to angiotensin 2, and so what you'd see is a big buildup of angiotensin 1, not very much angiotensin 2, and probably a normal amount of angiotensinogen. Maybe, depending on the feedback effects. So when do you use Aliskiren? In the case of hypertension. Of course, if you're stopping this here, since this triggers aldosterone as well, you're also going to have less aldosterone. All right, there it is. Some of the side effects are hypotension, makes sense. Rash, gastrointestinal distress, renal insufficiency. If a person has renal insufficiency, you don't give them this because it messes with their kidneys, and yeah. Also, don't give it to somebody if they're pregnant. Another thing to know about this is that is a strong P glycoprotein, or no, it's contraindicated, sorry, with strong P glycoprotein inhibitors such as cyclosporine. Excuse me. Metabolism is through CYP3A4. Okay. Now we've talked about Aliskiren. Here's a drug on Captopril. Okay, so Captopril, remember the prils? We talked about that a little bit earlier. Where do they take their effect? Captopril, ACE inhibitors, Captopril, they take their effect right here, right there. They're an ACE inhibitor. They inhibit this, so this never turns into that. If this never turns into that, then this can't cause all your blood vessels to clamp down, so it opens them up, expands them, which decreases the hypertension, which keeps the person alive. Okay, so it says mechanism is it reversibly inhibits angiotensin converting enzyme. Yep, very nice. Side effects, sometimes they get a cough with this. Great. All right, there it is. There's Captopril. Now let's talk about Spironolactone. I don't remember what this one does, so I'm going to look at it for a second. Spironolactone. So, let me erase this stuff. Spironolactone is a potassium-sparing diuretic. This drug is a synthetic steroid that is a competitive antagonist of aldosterone. Ah, there we go. Okay, so one thing I didn't draw on here. So, angiotensin 2 does two things. One is vasoconstriction, and also aldosterone release. Aldosterone. Okay, two things there. Aldosterone and vasoconstriction. Aldosterone, what it does is it makes you get more sodium, which results in more water. So it's working to fill this puppy up with water, pouring more water in there, retaining water really. Whereas the other effect of angiotensin 2 is to squeeze down to get that blood where it needs to go. Okay? So angiotensin 2 works two ways. One through vasoconstriction, one through aldosterone. So spironolactone, what it does, this is kind of interesting, is it goes to where angiotensin 2, or maybe where aldosterone. Okay, yeah. So this aldosterone, it travels down to the distal convoluted tubule, and there it binds to the distal convoluted tubule, and it causes it to spare potassium, so it retains more water and sodium and all that stuff. Anyway, retains sodium. So what happens in the case of spironolactone? Let me write it out here. Spironolactone, it's a diuretic. What this does is it goes over here to your distal convoluted tubule, and it blocks aldosterone from being able to bind. So it gets in the way there. So if aldosterone can't bind, then you're not going to have that increase in sodium. You're not going to have that increase in water. And so this isn't going to get as full up, and you're going to pee more. Okay? So when do you use this? You use this in the case of edema. Sometimes when people get really high blood pressure, they get really bad edema. Edema is like where your blood pressure is so high that the fluid goes from your blood vessels and goes into the surrounding tissues. And the surrounding tissues get all big and bloated with fluid. So if a person has that condition going on, you give them spironolactone, and spironolactone is going to go over here, go to the distal convoluted tubule, and it's going to block aldosterone from binding, which is going to cause you to pee out more water. Okay? Side effect is hyperkalemia, because it's potassium sparing, so you're holding on to too much. Okay, looks like triamterene, eplerenone, and amyloride are some other ones. They work a little bit differently, but I'm not going to go over that right now. Okay, hydrochlorothiazide. How does this guy work? This is a long name. Hydrochlorothiazide. Let's write it out here. Hydro makes you think of water. Chloro makes me think of chlorine, but I don't know if that has anything to do with it. Chlorothiazide. And I don't remember exactly what this one does, so I'm going to read it for a second until I figure it out, and then I'll explain where it fits in. Inhibits sodium-calcium transporter in the early segment of the distal convoluted tubule. Increase in urinary potassium excretion because reabsorption is less efficient in the face of increased sodium delivery to collecting duct. Also induces volume depletion, increased aldosterone activity, and increase. Okay, so basically what it looks like it's doing here is it's causing, it goes to this, so there's these little sodium in the distal convoluted tubule. This is in your kidney. This is all happening in here. You're just throwing minerals around all over the place. So it throws out sodium, and it brings the sodium back, and it throws out, there's this whole complicated process. But essentially what this is, and the process results in your body forming urine and holding on to water and different things like that. And so what this does, hydrochlorothiazide, is it goes in and it inhibits these guys, so that instead of you taking back all this sodium and water, this is inhibited so that the water and the sodium just goes right on through and into the porcelain throne. That's a toilet, in case you can't tell. So you pee it out. So hydrochlorothiazide inhibits the sodium chlorine chloro. It inhibits the sodium chlorine transporter, so you think of water, chlorine, thiazide, and so it makes you pee more. When do you use it? Use in the case of hypertension. Looks like maybe also with diabetes insipidus. Yeah, I won't worry about that now. Okay, so you can also use it for edema as well. Side effect is hypokalemia. Well, that might make sense because if you're messing with all this stuff, you might hold on to too much potassium. Also looks like, So, I screwed up. Hypokalemia. Hypokalemia means it looks like you're getting rid of it. That actually makes more sense. So you're taking the potassium that was up here. Instead of taking it back, this whole thing's inhibited. So it just throws out your potassium. You just pee out your potassium. You also pee out your sodium. So you're just throwing the stuff in the toilet. So you might get hypokalemia or hyponatremia or both. And it looks like you don't give it to somebody who has a sulfa allergy because it may increase the toxicity of lithium. Or I guess that's another contraindication. Okay, so there you go. There's hydrochlorothiazide. Now you know how it fits in there. Okay, so next drug. Now we're talking about something called furosemide. And again, I don't remember what furosemide does, so I'm going to read it for a minute and then figure out where it fits in. Furosemide. Oops, there it is. Furosemide. Looks like it's a diuretic. So how does furosemide work? It says that it inhibits the sodium-calcium reabsorption. Well, that's obvious. I already know what that's going to do.
So here's the distal convoluted tubule. I'm assuming that's the one they're working on here. No, this looks like it works on the ascending loop of Henle. Okay, so there's this whole thing. It comes down like this, and then it gets thin, and kind of thin loop, and comes back up, and then it's a thicker loop, and then it just does this whole thing in your kidneys, this whole process of getting rid of water and retaining water. So anyway, there's this part on here called the ascending limb of the loop of Henle. So you got this little loop of Henle. So the ascending limb, the loop of Henle. And what it's going to do is it's going to inhibit sodium chlorine reabsorption. So first of all, what it does in a lot of cases is it dumps stuff in there and pulls stuff back out, and it does this repeated times. So essentially, at one point, normally it would dump sodium and chlorine back in here, and the water would go in here, and it would come out as pee. But in this case, it says that I did the other way. Normally it would pull back the sodium and chlorine, so your body keeps it, and the water would go with it. But in the case of furosemide, what it does is it inhibits your body's ability, in the ascending loop of Henle, it inhibits your body's ability to pull that sodium and chlorine, or sodium, potassium, and chloride, back into your body. And if you inhibit the ability of your body to pull, your ascending loop of Henle, to pull those ions back, it means that your water isn't going to get pulled back either. So that means that you're going to have more of these ions in here, which means you're going to have more water in here, which means you're going to pee this stuff out. And if you pee this stuff out, then you're going to decrease the amount of water in your circulation. So, yep, there it is. So when are you going to use it? If somebody has lots of edema, and it can cause hypokalemia, and looks like also reversible ototoxicity. And you don't give it to somebody who has a drug that's allergic to sulfur allergies. You give it by mouth or by IV. The half-life is 2 to 3 hours. So there's furosemide. That's how it works. So again, it's diuretic. It makes people pee more. It inhibits the sodium, potassium, 2-chlorine transporter. All right. Now we're going to move on to acetazolamide. Acetazolamide. Also looks like it's called Diamox. So how does this work? I don't remember, so I'm going to look it up. This says it's also diuretic. It says it inhibits carbonic anhydrase, which catalyzes HCO3 to CO2 plus OH in the proximal convoluted tubule of the kidney. It says normally carbon dioxide then diffuses into the proximal tubule cells and recombines with OH negative to form HCO3, which is transported to the basolateral membrane in the bloodstream. Thus, inhibition of calcium results in decreased reabsorption of bicarbonate. Okay. So essentially, this one's a little bit more confusing. This is used in the case of glaucoma. So it looks like what's happening to me is that this has something to do. So there's a couple ions that are thrown around in here. You know, you've got sodium is thrown around. You've got potassium that's thrown around. You've got chlorine that's thrown around, and you also have bicarbonate that's thrown around, or HCO3 or whatever. That's thrown around as well. And essentially, what this does is it inhibits something called carbonic anhydrase. Carbonic anhydrase. And what carbonic anhydrase does is it takes HCO3 negative and it changes it into CO2 plus OH positive. Where does it do that? In the proximal convoluted, there's the proximal convoluted tubule of the kidney. So normally the CO2 then diffuses in the proximal tubule and recombines with OH. Okay, this is a little bit more complicated than some of the other stuff, but essentially, get the general idea. Acetazolamide, when you use it in the case of glaucoma. Glaucoma is when somebody has too much fluid in their eye and it's getting so big and burst that it could damage your eye and your vision and everything. So in this case, use acetazolamide to mess with this whole process that involves HCO3, CO2, and OH positive in the proximal convoluted tubule, that essentially is going to result in, I think, the person peeing more fluid out. Okay, they're probably going to pee out more bicarbonate, I'm guessing. I don't know. Yep, whatever. So there you go. So you pee out more fluid. That's the general idea. Got it? Good. Okay, so now we've talked about acetazolamide. Use that for glaucoma. Now let's talk about mannitol. How does mannitol work here? So mannitol, looks like this is also a diuretic. It's an osmotic diuretic, not subject to tubular reabsorption. Oh, so this is simple. All this is doing is you drink this stuff, the mannitol goes in, and it's this ion. Remember, water likes to follow ions. So this mannitol, let me write it up here first. Mannitol. This ion goes in here, and when it goes in there, water sticks to it. See all the water sticking to it? And this stuff does not get reabsorbed, ever, which means that it just pulls the water, grabs onto all this water, and it just sucks the water with it. Never gets pulled back all the way here, and then you pee out the mannitol, and with the mannitol, you pee out the water. So that's how this stuff works. That's pretty cool. So clinical, maintain, so you give this to somebody, let's say that they have I don't know. It says here the clinical use is to maintain high urine flow. So sometimes you give somebody a drug and you really need the people to pee this drug out fast, or maybe they have some other issue going on with their kidney, and if you want them to pee a lot, you give them mannitol. And mannitol is going to make them pee out a lot of fluid. So also it decreases intracranial or intraocular pressure through volume depletion. So if a person's got too much volume, you give them some mannitol, they get rid of a bunch of it. If they've got too much pressure in their eye, there's too much fluid, that'll decrease that. Or they have too much pressure in their brain, too much blood, get rid of that. So yeah, looks like it's pretty straightforward. Looks like the drug is poorly absorbed and therefore must be given parenterally or through the tissue. All right, very nice. So that's mannitol. We've got 4 drugs left to get through all this little stack of drugs here that I want to get through. So now we're going to talk about digoxin. And I don't remember what digoxin does, so we're going to find out here together. Digoxin. There's digoxin. What does digoxin do? It says it inhibits the sodium-potassium ATPase pump, causing an increased intercellular sodium, which impairs the sodium-calcium exchanger and results in increased intercellular calcium, increased stores of calcium in sarcoplasmic reticulum, allows subsequent reaction potentials. Okay, you know what? These drugs look like these are of a different class, and they don't fit in with my picture, so I'm going to end this video. Hope that you learned something. I know that I did.